This is the precepts slide of the last week's talk about this is the very important sign after Oxford Uni, especially after cementless Oxford knee. Okay, please wait. Okay, welcome. So typically 1 or 2 weeks after operation, we can see there's some space between here and here. So it is a very important sign, the subclinical sign of the fracture. If the patient continue the full weight bearing, the fracture can occur after 1 or 2 weeks. So if you find this table sign, this is a separation from vertical cut of the tibial and lateral wall of the tibial tray. So you should stop the weight bearing and keep waiting. But sometimes, maybe I will show you later, sometimes you can find the healed fracture after 3 months or 4 months later. It is very rare, but typically the patient cannot walk and they need some intervention over the operation. Okay, and so this is some solution to avoid the fracture, especially the cementless fracture after Oxford knee. So this is the virus cut. So to incline the 2 or 3 degrees in the virus alignment should be safer than the perpendicular cut, because the most patient, the Asian patient, have the tibial bala, proximal tibial bala. So in this patient, if we cut the tibia perpendicular to the tibia axis, eventually that cutting line can be the valgus alignment in terms of the medial part of the tibia. So, but unfortunately, there is no tool to make the valgus cut using the Oxford knee instrumentation. So, what I just devised the good tool to cut the proximal tibia in the valgus alignment. Maybe in the near future, I will show you. It's very, very convenient. So, but even in the very risky patient, so the patient has the overhang medial condyle and very small size and very osteoporotic femurs, it is very safe to use the cemented. So because in the cemented implant, we can get the bonding connection between the here vertical wall and vertical wall of the tibia tray. But in contrast, the cementless implant, there is no bonding force between here and here. That is the one reason to the high frequent after the cementless Oxford knee. So if the surgeon worry about some post-operative fracture, the surgeon should use the cemented. But why we use the cementless? Because after the cementless, the radiolucent is very, very rare compared to the cemented. So the radiolucent after the cemented UKA sometimes misunderstood as a loosening. And we are very, very worried about the patient has a radiolucent and the patient has still pain even after 6 months and 1 year. We are very worried about it and patient, and we are very stressful. So to avoid this, the cementless is very biological and the perfect bonding between the bone and the component that can be achieved. So basically I want to use the cementless just like THA, but so far it is impossible to use the cementless in every patient. So because this is a characteristic of the cementless, to get the initial fixation, this we need the interference. That means the narrow slot for the keel compared to the width of the keel, because if impact of this keel into the narrow slot on the tibia can cause the impaction from the side. So that can improve the initial fixation. That can accelerate the biological bonding between the tibia train and to the bone. But in the contrary, in the cemented knee, we need some cement mantle between the keel and the slot. So this slot is wider than the keel width. So this is the difference. So using the cemented, there is no impaction force. There is no interference, no separation force can be act on the bone surface. So these are treatments. So maybe I showed this slide. This is depend on the united or not united, and the balance deformity is acceptable or not acceptable. So I will show you some results. Oh, this is my first case of the tibia fracture. So unfortunately, this is the kind of a technical error because the vertical cut is too medium and horizontal cut was too low. And you can see the alignment of the tibia cut. Then we are focused on this hole. This fold is correspond to the most lateral fold of the tibial cutting block. It is located on the tibia axis. So in this point, this placement is too medial. That can cause the too medial vertical cut. So we can see the complete shape of the medial tibial spine. So in fact, so base point is just medial to the top of the medial eminence, medial tibial spine. So eventually, this is the keel. This keel is very close to the bone cortex, the both anterior and posterior. The patient had a fracture 2 weeks after the operation during the hospital stay. Okay. So I revised to the total knee using the long stem. In this patient, we only use the flat tibia tray. We never use, in this case, I didn't use the augment of the tibia because this stabilization is achieved using the stem and the lateral surface. So thanks to the two medial bone cuts, after the bone cut, so we can get a normal bone surface of the middle on the lateral part of the tibial plateau. So the medial part, the fracture part, is a very small part. So I inserted the tibia tray and use this bone fragment as a bone fragment and insert beneath the medial tibia plate and fix using a cement. This patient I followed up approximately 8 years. The patient is still happy. This is the second case. Another case is this is a very, very special case. This is just after the operation, but the patient discharged our hospital event-free. But just after the discharge from our hospital, the patient felt pain, but the pain disappeared gradually, and he came to the first visit to our clinic 3 months after operation. At that time, I found the completely healed the fracture. It is 3 months later. This is already united, and alignment comes as slightly vellus. Please compare the alignment just after the operation, 3 months after the operation. And in addition to there is a space, so-called takeoff sign, approximately maybe 1 or 2 millimeters. And this is the vellus alignment. So unfortunately, the vellus alignment is similar between the fracture and the unfractured side. So this patient accepts this vellus alignment, and or maybe this patient is maybe 3 years after the operation. The patient is still happy. So this is a very lucky case. But after the cementless component, we can't like this, because in the future, the bone will fill between this gap due to because of the hydrogen apatite coating here and here. So even after the fracture and the separation from the bone and component, the bone filling can occur. This is the benefit for the cementless component. In contrast, cemented component, if we can some space between the cement and bone, so-called sacral sign between the cement and bone. I don't know if the feeling and strong bonding between the bone and cement can be achieved or not. So maybe this is a special situation for the cementless component. Oh, this is another case. This is also cementless, but the patient suddenly felt pain during the rehabilitation, and we found the small crack using the CT scan just below the keel. So I discussed with the patient, and we decided to fix this fracture using the cannulated screw, 2 cannulated screws, and limitation of weight bearing for 4 weeks, and then fracture healed and eventually. And also, this patient is happy so far. So this is another case. It is a preoperative X-ray, and this is just after the operation. It is quite typical case because this patient has very, very obvious proximal tibial vara. So we can easily evaluate the proximal tibial vara and very overhanging medial femoral tibial condyle using ME line. This is the line parallel to the tibial axis, and it passes at the tip of the medial tibial spine. So this line obviously passed outside of the bone. That implies the patient has the very overhanging medial femoral tibial condyle. That means that the patient has a very, very severe proximal tibial vara case. And this is just after the operation. This cutting line is perpendicular to the tibial axis because we can see the hole here. This is the landmark of the tibial alignment. So this is come just between the medial and the tibial lateral tibial spine. And of course, the Oxford alignment rod is securely fixed at the center of the lower tibia. So this alignment is perfectly parallel to the mechanical axis of the tibia. And this is virtually perpendicular to the tibial axis. But if we are looking the shape of the proximal tibia, so this alignment looks some valgus alignment. So in the patient with the conditional varus tibial patient, the perpendicular cut comes the valgus cut in terms of the proximal part of the tibia. So this is a very tricky point. So 2 weeks after the operation, we find the fracture beneath the keel and vertical fracture. Then fix using the plate. Maybe this is the standard procedure to treat the tibial fracture after the Oxford UKA, because this keel is sometimes an obstacle inside the screw or pin. So have a look. The all screw is concentrated on the lower level of the keel. So ideally, if we can insert the screw here and just beneath the tibia tray, it should be the perfect. But there is only a limited space. The anterior or posterior to the keel is very limited, so quite difficult to insert. So we set the locking plate just below the tip of keel and insert as many screws as possible. So this is another case. It is also a necrosis case. And this is just after the operation. But unfortunately, we found the post-operative fracture 2 weeks after operation. I discussed with patient and decided to revise using the total knee with the short stem. And have a look. I implanted this component in the slight varus position because there is severe bone loss. So slight varus alignment can decrease the amount of the bone loss. So eventually I selected the short stem to fix here. And maybe this patient is 5 years after the operation, so bone is completely united and the TKA acts very well, works very well. So the patient is very happy. So in previous report, the revision to the TKA after the UKA is the similar result to the TK revision from the TK to TK revision is similar to the UK to TK. And the result is worse than the primary TKA. So we should avoid the revision of the UK to the TKA because the result is not unpredictable. But I believe so if we do the good operation, so the result is similar to the primary operation. In our hospital, there are more than 10 revised cases from the UK to the TKA, but every patient is very happy and going very well. So in the revision UKA, I recommend to use the double cut technique. This is a slide is explaining the complexity, the difficulty of the operation procedure after the UKA. regarding to the femur side, the coronal alignment is very difficult to decide because distal end of the femur is already removed to adjust the pressure gap and extension gap. So to decide the distal alignment, so if we are happy if we can use the PSI or navigation, but in most institutions, it is impossible to use them. So, so I recommend to cut the distal angle, distal level to the before the revise the femur component. So the target should be the lateral condyle. Thanks to the normal lateral cartilage, the both femur and the tibial side, we can cut the 9 mm from the lateral condyle and then cut the 6 degrees in the varus in all cases. And rotation alignment is very difficult to decide because we cannot use the PCA, posterior condyle axis, because the medial posterior condyle is already gone. And we cannot use the sizer to decide the rotation of the tibia component before the revise the femur component, because the femur size is measured after the distal cut of the femur. So only we can use the SCL, surgical epicondylar axis, or wide side line. But augment is rarely necessary because the thickness of bone cut should be approximately 4 or 5 millimeters. If some bone is retrieved during the the removal of the component, so even after the retrieve the femur component, and even the component has some piece of bone from the posterior condyle or the femur, so thickness should be enough. So small gap can be filled using the cement. And the tibial side is a gross bone defect is a problem. Basically, the bone graft or augments can be used. But I recommend to use the double cut technique like this. So cut here, before the final cut of tibia. This is the normally the 10 or 12 millimeter below the joint line. Before the final cut, I cut just below the subcondylar bone of the lateral condyle, and then cut to the final line. So all this line should be the 10 millimeter or slightly lower. You don't necessarily to adjust the bone DX side of the medial side. You can see only the lateral side. And cut the surface, and then cut the 10 millimeter below the joint line. Then you can get at least 8 millimeter bone block like this. So you can remove, and you can get the bone plate like this, and put on this bone here, and implant on the tibia component. I recommend to use the stem and sometimes augment. But augment is rarely necessary because we can easily fill this space using the bone block from the lateral condyle. And stem is, there is a very good bone quality lateral side and the center of the tibia condyle. The bone defect can be seen only the medial side of the tibia palatal. So most part of this tibial component can be supported by the normal putting surface. And in addition, if we use the long stem, the stability is enough. So the augment rarely necessary, but I strongly recommend to use the stemmed tibia, because a study shows that the revision rate after the revision revise of the UKA compared to the TKA. The revision rate is higher if the patient did not have the stem or augment. If you use the stem with or without the augment, the revision rate decreases significantly. So I strongly recommend to use the stem for the tibia. So this take-home message: the half of the cause of the tibia fracture is a technical error. Never use a heavy hammer. Never use the medial holes. If you make the hole, so near on the cortex near the keel, you can experience the fracture. So never too low and never too medial. And great care must be taken of the cementless tibia. So I don't recommend to use routinely cementless tibia, even if it is available in your country. So you should only limit it for the male patient or big bone frame patients. And be careful of the proximal tibial buttock. So please use every line. And be careful of the small tibia. And don't miss the takeoff sign. I strongly recommend take the true AP X-ray 1 or 2 weeks after the operation using the fluoroscope. Then you should compare just after the operation and 1 week or 2 weeks after the operation. So that you can find some separation, so-called takeoff sign. And some patients have a very severe pain. Normally it occurs suddenly. So at that time, you should take care. So you should take the true AP line, and you should find the takeoff sign and some small plug and the key to the cortex. Okay, this is the end of my talk. So maybe in the Asian countries, the fracture is very, very important and serious complication. It is very specialized in the Asian countries, especially in the Japan. So you should exactly understand why the fracture is so frequent in Asian countries. You should take care, and you should find some risky patient in the both for the cementless. Of course, cementless is more risky, but the risk is similar between the cementless and the cemented. If you do the UKA for the patient unsuitable for the UKA, the patient has very small and proximal tibial buttock. If your operation is improper, for example, too medial cut or too low cut, sometimes too deep cycle cut, or improper preparation of the keel throat, they can cause a fracture. And you should check if you have the fracture. You should check the shape and the location of the fracture and discuss with your patient family, and which treatment is the best: conservative treatment or bone union, osteosynthesis, internal fixation, or arthroplasty. So you should know the individual characteristics, the features of such treatment, and select the best solution for the patient. Okay, thank you very much. Okay, the next week I will prepare another talk. So, and if you have any question and comment, not to specialize in the fracture, everything is all right as long as this is related to the Oxford knee or normal TKA. Please send me an email or a comment or message. Okay, see you. Thank you. See you next week. Bye. Have a good night.